Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with colon and rectal cancer management? Find out more right now. My guest this evening is Dr. Mark Goldstein, a noted cancer specialist right here in Montgomery County. Mark, welcome to Housecall.
Good evening. Thanks for having me. I appreciate the invitation, Dr. Doman.
My pleasure. So, Mark, briefly tell our viewers about your professional background.
So I started off with a genetics major, University of Georgia, and went to St. George's for medical school, some of it which was out of the country and some was in Brooklyn, New York. And I spent the rest of my training from internship through hematology and oncology fellowship at the University of Connecticut. So I am board certified in internal medicine, hematology, and oncology.
Very nice. And where do you practice in Montgomery County?
So our practice has two offices, one in Bethesda and one in Germantown.
Right. So briefly tell our viewers the difference between the colon and the rectum.
Essentially, the colon begins where the small intestine ends, sort of near the appendix, and comes around the abdomen. And as it gets to the very end, it changes to the rectum at just the last segment. And the final exit point, of course, is the anus. So rectum is the last segment after the colon ends. So it's a particular structure that is down in the pelvis, and for that reason, its management when cancer arises is different than that for regular colon cancer.
I should, before we go on with our discussion, explain that I've been very much looking forward to our dialogue, because here you are, a cancer specialist, and I'm a gastroenterologist. So we have our own unique perspectives on this topic.
Yeah.
So given that they are somewhat different, albeit connected, the colon and the rectum, tell our viewers, what are some of the symptoms of colon cancer?
The symptoms depend somewhat on the location of the cancer. So for example, if a patient has a cancer in the first part of the colon, the stool is more liquid on that side, and it may take some time for the patient to get symptoms, but symptoms could include weight loss, sometimes pain, but very often early on, there's no symptom, which is why, of course, colonoscopy is encouraged for screening. On the left side of the colon, which is further down and getting closer to the rectum, stool can sometimes be more narrow as it's trying to pass through this tightened area. Sometimes blood can pass, and sometimes patients do have pain or pressure, whether or not they're moving their bowels.
What are the stages of colon cancer in both the colon and in the rectum?
Like most other cancers, it's stage 1, 2, 3, and 4. And for the most part, when patients have lymph node involvement in the neighborhood of the tumor, it's stage 3. But if the cancer has spread to other organs, it's stage 4, such as to the liver. Earlier stages depend upon how deep in the muscle wall of the colon the tumor is penetrating, and that is either determined at the time of surgery, or in the case of rectal cancer, very often determined by MRI.
So if somebody does have stage 4 advanced cancer, and it's already spread, for example, to the liver, as you mentioned, is that definitely a bad prognosis, or is it potentially curable with today's state-of-the-art therapy?
If it's stage 4, we wouldn't suggest that it's curable. It's hard always to tell in the beginning of that diagnosis how bad of a prognosis it is, even though it's not curable. So for example, if a patient has a colon cancer and a single liver lesion, you can sometimes resect both of them and treat the patient almost as if they're a stage 3, with the intent of quote unquote cure. If a patient instead has numerous liver lesions, you can't really do that. And those are more challenging patients. But inevitably, those patients will need lifelong therapy.
You mentioned patients with earlier stage colon or rectal cancer have a better prognosis, better outlook. So how can a patient lower their risk of ever developing colorectal cancer or even prevent it?
When we're relating stage to prognosis, your best bet is to get screened and get it caught early. And even better, if you're getting screened and a polyp is found and you have that polyp removed, you can effectively prevent colon cancer. So unfortunately, not a lot of people are of the eligible population are getting their colonoscopies, which is why they've developed other tests like the Cologuard stool test, and they're trying to find other ways to make sure patients get screened. But ultimately, the best thing to do is get screened and catch it early, or prevent it.
The latest data within my specialty is 50 to 60% of eligible patients are getting colonoscopy. Hopefully, with the Cologuard being embraced by at least a subset of the population, that will further increase our utility for colonoscopy.
Yep, I agree. Yep.
What are your thoughts about the X-ray CT virtual colonoscopy?
Very few people that I know of have ever done it. There's been a couple special circumstances, but my understanding of that test is that you still have to do the prep, but if they find something that looks suspicious, like a polyp or even a tumor, you still have to do the colonoscopy subsequent to that. So it's a lot of patients, I think, believe that if they do it that way, they won't ever need a colonoscopy. But certainly if it comes out clean, you can avoid the colonoscopy. But I believe you still need the prep, and that's the part that people tend not to like.
Right. And certainly we reserve it for those patients that may need to be screened, but are not good candidates for anesthesia and a state-of-the-art colonoscopy. I agree.
Right.
If somebody comes by to see me, for example, and I do a colonoscopy and I find a colon cancer, usually at that point, I'm ordering x-rays to stage it, see what is the evidence of confinement to the colon or spread elsewhere, and they go off to surgery. So what happens then? They go to surgery, and after the surgery, when do you get to see them?
I like to actually see the patients before they go to surgery, because there can be extenuating circumstances like anemia, which is common, and the patients need iron. And sometimes it's good to tune the patients up before they go to surgery. But and it also helps to set some expectations of tell the patients, if they find this, we're going to do that. If they find this, we're going to do that. And so the patients have some understanding of what's about to happen. But very often the patients do go straight to surgery, assuming the scan doesn't show that the cancer has spread anywhere. And then we get the pathology report back, which gives us the pathologic staging. And from there, we turn to the NCCN guidelines and determine who needs chemotherapy and who does not, in order to reduce the risk of recurrence.
Now, what's interesting, though, is you said at the top of the show, the biology somewhat of rectal cancer and colon cancer is different. Do you find that if somebody has a rectal cancer, you may want to flip that formula we just reviewed, that you may want to do some chemotherapy or radiation to set the stage for surgery?
Exactly. So for rectal cancer, very often we do the scans up front, like with colon cancer, but we would include an MRI of the pelvis, which helps with the staging, and it helps the surgeon with the anatomic landmarks. And then the patients will often get treatment first, assuming it's not stage 1. So they would historically be given chemotherapy and radiation for several weeks, then go to surgery, and then get chemotherapy by itself for a couple of months. The new paradigm, which is called TNT, total neoadjuvant therapy, the patients will get the chemo and radiation at the same time for a few weeks. Usually it's a chemo pill to take every day, pretty mild on that front, followed by a 2-drug chemo regimen for a couple of months, and then have their scans done again. And if everything looks good, they go for surgery. You can reverse that. You can give chemo first and then chemoradiation, and again, go for surgery afterwards. Once the surgery is done, the patients are pretty much done with therapy. The exception to this regimen is what we're hearing is being done more and more in Europe, where the patients get this T&T protocol, and if the subsequent scans and MRIs show no evidence of residual disease, the patients will sometimes not be taken to surgery. That's not yet standard of care here, though.
Why do you think the biology of rectal cancer and colon cancer, literally next door, is different?
Well, it's hard to say, actually. I don't know the answer to that. I'm not sure that it is a whole lot different on the biology side of things, because it tends to respond to similar chemotherapy agents, actually identical chemotherapy agents, both in the stage 2, stage 3 setting, and even the stage 4 setting. The growth rate in a metastatic setting can be very similar. So there's a lot of similarities there, actually. I think it's just the fact that when you're dealing with the rectum, you have an opportunity with a fixed structure to offer radiation, whereas in the colon, it's not that fixed. And it would be very difficult to radiate that, and also very difficult to avoid other structures. So it's been shown, though, that adding radiation to the mix does improve the local control and can downstage patients before they go to surgery. That's a different aspect of the management, which isn't really the biology specifically, but the idea is that you can take someone who, for example, would never be able to get through a surgery because the tumor is too invasive, and now you downstage them and now made it possible for the surgery to take place.
We're going to pause briefly for a public service announcement. When we return, more with my guest, Dr. Mark Goldstein, cancer specialist in Montgomery County, and we'll be discussing colon and rectal surgery. We'll be right back.
I'm working in a job that I love.
Because I was given a chance.
To show that my disability
is only one part of who I am.
Who I am.
Who I am.
At work, it's what people can do that matters.
For more information, visit whatcanyoudocampaign.org.
We're back. My guest this evening is Dr. Mark Goldstein, a cancer specialist in Montgomery County, and we're discussing colon and rectal cancer. Mark, when we paused for the break, one of the topics I wanted to bring up was which sort of X-ray studies do you order to evaluate and stage somebody with colon or rectal cancer?
Great question. So for colon cancer, we almost exclusively use CT scans, or CAT scans, as some people call them, of the chest, abdomen, and pelvis. And we do them with oral and IV contrast. So that's very important. I've seen a lot of patients coming through, the emergency room, and they have a CT scan, and then they get diagnosed with colon cancer, but they never had contrast. So you always have to make sure to do that so you can make sure you're not missing something in the liver, for example. Occasionally we do PET scans if someone has bad kidney function. They can't do the IV contrast for CT, but a PET scan, they get essentially a sugar injection, which will help to identify tumors. So in the rectal cancer situation, in addition to the CT, we would also add an MRI of the pelvis with gadolinium contrast, IV contrast, in order to, again, better define the structures down there. We don't really need that in most cases for colon cancer, unless we're still suspicious of something in the liver that wasn't showing well on CT.
When do you decide if you're going to give radiation therapy alone or chemotherapy, or both?
So for rectal cancer, again, this TNT, total neoadjuvant therapy, includes a component of chemo with radiation, and it also includes a component of chemo only. So that's a pretty standard protocol for most patients that I see who are going to have surgery later. For the patients who have very early stage, let's say stage 1 rectal cancer, they might be able to get away with surgery only. In the colon cancer world, it's a bit different. Patients tend to go to surgery first. And again, if they have more advanced disease, let's say stage 3 disease, lymph node involvement is a good example of the scenario. All of those patients are considered for chemotherapy. The rules of engagement are changing though, because it used to be pretty simple. If you had lymph node involvement, you get chemotherapy. If you have stage 2 with no lymph node involvement, you don't get chemotherapy. But now what's happening is we're starting to include blood tests, circulating tumor DNA tests. If that test is positive 4 weeks after surgery, there's a 97% chance that patient's going to recur if they don't take chemotherapy. So even if they're stage 2, and historically you might not have considered them for chemotherapy, in this case you would, and vice versa, if the test came back normal. So some patients may be able to wiggle out of chemotherapy if the test is normal. So those are important considerations these days that we used to not have.
When you mention circulating DNA, that's to imply that DNA is abnormal, and it's a so-called variant on a liquid biopsy, right?
Essentially, yes, they're looking for pieces of DNA that are unique to the tumor, that are trackable in the future, that can't be confused with some other random piece of DNA floating around.
Let's go on to discuss chemotherapy. Our patients, our viewers by extension, are aware of some of the bad rap that chemotherapy gets. Discuss with our viewers what some of the side effects are potentially with chemotherapy, specifically for colon and rectal cancer.
Great question. So first, I'll say that I'm a bit spoiled having started my oncology training in 2005, because we already had new medications to prevent nausea and vomiting. Before around the year 2000, the treatment for chemotherapy was pretty rough because they didn't have any good anti-nausea meds. So a lot of people say one of the best advances in oncology was the anti-nausea meds that came out, like Zofran and Emend and a few other ones. So with that on board, the thing that people fear a lot, nausea and vomiting, is, I don't want to say it's entirely a thing of the past, but it is much easier to control, so much so that almost every patient exists outside the hospital during chemo, and many of those patients can work full-time jobs during chemotherapy and not get sick in that way. The other toxicities from the chemotherapies varies widely depending on the drug, but commonly neuropathy, which is numbness or tingling of the fingers or toes, can progress month to month. There can be trouble with the blood counts, which puts you at risk for infection or anemia. And some of these are serious, some are not. Most are reversible. The chemo that we generally use for both rectal cancer and also for colon cancer are very similar drugs. And the thing that most patients are concerned about, which is hair loss, is actually not a typical side effect. You can go through 6 months of chemotherapy and actually not lose your hair.
Let's go on then to a newer generation of therapy, immunotherapy. When do you decide to add immune therapy? First of all, define that for our viewers.
So immunotherapy, in the sense that you mean, is a medicine that effectively alters the signal between a white blood cell and a cancer cell that may be docked together, where the white blood cell is being told by the cancer cell not to eat it. And the immunotherapy changes that signal, so you're taking the foot off the brake of the white blood cell, so it will actually attack the cancer cell. So although there's lots of antibody treatments out there for cancer, when we talk about immunotherapy, that's usually what we mean. So the use of these drugs, although there's well over 20 different indications for immunotherapy across different kinds of cancers, is not routine in either early stage colon cancer or metastatic colon cancer. Generally speaking, there are exceptions though. The hottest one lately is an immunotherapy that was tested in rectal cancer patients, not a large number of them, however, where if they had a certain genetic feature on the tumor cells, and I'm using that genetic feature terminology very loosely, if they had this feature called mismatch repair deficiency, there was a 100%, not just response rate, but a 100% complete response rate, meaning every patient who had that feature, who got immunotherapy with no chemotherapy, had a total eradication of their cancer. And therefore, those patients, if treated like that in the clinic, would probably not ever get radiation or surgery.
That's very impressive. So now our viewers are wondering, why don't you give immune therapy to everyone?
Well, again, first, it's only for rectal cancer so far. It's only for patients who have that genetic feature on their tumor cells.
Right.
And there were less than 20 patients on the clinical trial. So they're going to now move into broadening the studies so that we can get more data. So it's coming soon, but certainly not the majority of patients have that feature. So it's not going to be offered to everybody. I will say though that every patient diagnosed with colon or rectal cancer these days is being screened for those features because of trying to identify patients for a hereditary cancer syndrome called Lynch syndrome. So that becomes relevant in other scenarios, but that is now standard of care to have the pathologist test everybody.
Do you think over the course of the next few years, there'll be more and more genetic markers detected for colon and rectal cancer to allow you to use individualized specific immune therapy?
Absolutely. Absolutely. So about 20 years ago, there was very little in that regard. Then in the mid to late 2000s, we started using different kind of antibody, not specifically immunotherapy, but these were found to be most useful in patients who actually did not have certain gene mutations. If the patient had the gene mutation, it predicted that that drug would fail to help the patient with stage 4 colon or rectal cancer. And then fast forward a couple of years, we now have other genes that you can test. And if you have that feature, there is a pill. So if you have an NTRK gene fusion, for example, there's a pill for that. And BRAF mutation, there's a pill for that. So that is already happening right now. And we use that in the clinic setting, without being in a research setting. And so that is still in development, and they're finding more and more targets and developing more and more drugs for those targets.
Let's go on to discuss what you mentioned earlier, recurrence of cancer, metastatic disease, whether it's colon, origin, or rectal. What are some of the signs and symptoms of metastatic cancer?
So in a patient who was previously diagnosed, we might be monitoring them with blood work, and we might find evidence in the blood work before the patient has symptoms. But if a patient has fairly far advanced disease, whether it's recurrent or it's a new diagnosis, very often those patients will have weight loss, lack of appetite, as more non-specific symptoms, but they can be progressive, and that can be a signal of a problem like that. If the patient has extensive liver involvement, they might have pain in the right upper quadrant of their abdomen. We don't see that a lot, but it does happen if they have large tumors there or extensive liver involvement. So those are some of the more common things that we see. Now, it is dependent upon where the cancer spreads. So if the cancer spread to the lungs, either they'll have no symptoms, they could have a dry but progressively worsening cough, shortness of breath, as opposed to the belly pain.
You mentioned earlier testing to pick up recurrent cancer. Tell our viewers what is the CEA. What does that stand for?
The CEA is a carcinoma antigen that is not absolutely specific to colon or rectal cancer. We use it, and we've been using it for over 15 years to track colon cancers. It's important to know what their baseline is. So if they had stage 1, 2, or 3 colon cancer, it would be good to get that done before surgery, so you know whether or not it was abnormal at all. But assuming it was abnormal and you treat them and it goes below 3, let's say, which is in the normal range, then you check it every 3 months for up to 5 years. And if you start seeing the number go up, then you have to investigate and see if the cancer has come back. That's the way we've been doing it for years. On an investigational level, which will probably become standard of care, is the ctDNA we were talking about earlier. And that also can be tracked on a roughly 3-month basis. In theory, if that becomes abnormal, because it's very sensitive, it can detect recurrences very early. The manufacturer claims that the window until they become either symptomatic or until you can find the cancer on the scans can be up to 16 months out. So those patients, if the CEA is normal, but the DNA test is abnormal, I start scanning those patients every 3 months rather than once a year like we would normally do.
And when you're looking for metastatic disease, do you favor a CT scan or the PET scan?
For colon and rectal cancer, it's usually CT scan, again, with contrast. But again, if there's some suspicion of cancer and the CT doesn't show anything, the next scan will often be a PET scan. And if that still doesn't show anything, I might turn to an MRI to look at the liver, because PET scans, in my experience, only show things in the liver that are extremely active or large, not the small stuff. And so MRI is more sensitive in my experience.
So if somebody has stage 4 cancer and you've treated them with a variety of therapeutic options you've reviewed this evening, and you get follow-up testing and scanning, and there's no evidence of recurrent disease, it's all disappeared, what do you do at that point?
Yes, we got that question quite a bit. So they've done studies years back that looked at maintenance therapy versus no maintenance therapy. And it seems that doing maintenance therapy can help someone maintain that complete response for a longer period of time. So that does require staying on some kind of chemotherapy. Very often patients will be given a oral chemotherapy as a single agent drug, 2 weeks on and 1 week off indefinitely, in order to just keep it at bay. Because if you don't do that, inevitably the cancer will come back earlier, not necessarily more aggressively, but just come back earlier. So if you're trying to help someone stay out of trouble and they seem to tolerate that and it doesn't impact their quality of life a lot, you can do that for many months and delay the recurrence.
Very good. Well, thank you for an excellent interview. It's been a pleasure.
Thank you for having me. I enjoyed it. Thank you so much.
My thanks to Dr. Goldstein for a superb interview on colon and rectal cancer. My thanks to my team at the studio, and most important, thank you, the viewer, for joining us this evening. You can reach me at my practice website. Let us know how we're doing. Look forward to seeing you next time for another edition of Housecall. Good evening.